He was 80 years old, and the surgery went exactly as planned. The tumor was removed, the margins were clean, the surgical team was satisfied. His family was relieved. They hugged each other in the waiting room. They believed the hard part was over. 3 weeks later, he was dead. Not from the cancer, from the surgery. The cancer had been small, slow-growing, and almost certainly never going to kill him at his age. But the operation triggered a cascade his body could not survive. A blood clot, then a hospital-acquired infection, then organ failure, one thing after another, in a body that no longer had the reserve to fight back. The surgeon had done nothing wrong. The cancer was real. The decision to operate was made in good faith, following standard protocol. And it still killed him. This is called futile surgery, and it happens far more often than any statistic you have ever been shown reflects. My name is James. I am not a surgeon. I am not an oncologist. What I am is someone who has spent years reviewing the clinical literature on surgical risk in older adults and translating what that evidence actually says into language that people facing these decisions can use. This channel exists because there is a gap between what the research shows and what happens in the average oncology appointment. I am here to close that gap for you. Before we go any further, this is education, not medical advice. Every cancer case is different. Every patient is different. Nothing in this video replaces a conversation with a qualified oncologist who knows your specific situation. What this video gives you is the information you need to make that conversation count. Drop a comment right now with just your age, nothing else. I want to see who's watching. Here is what the standard medical system does when cancer is diagnosed in an older patient. It runs the same playbook it runs for a 50-year-old. It identifies the tumor, it stages it, it presents a treatment plan, often surgery first, and frames the decision as, "We found it, now we remove it." That framing feels logical, it feels responsible, it feels the right thing to do. Nobody told you that this framing was designed for a different body. The surgical protocols used in most hospitals in this country were developed primarily in patients between 40 and 65 years old. The risk models, the recovery expectations, the decision trees built for a body with full physiological reserves, a body that can absorb the stress of general anesthesia, a major incision, post-operative immobility, and the infection risk that comes with every hospital stay. When you are 70, 75, or 80, that body is not your body. This is not an insult. This is biology. After 70, the physiological reserve that carries a person through major surgery, cardiac function, pulmonary capacity, immune response, muscle mass, declines in ways that standard pre-surgical screening does not fully capture. A patient can pass every standard pre-op test and still be what geriatric oncologists call frail. Not frail in the way you see it, frail in the clinical sense. A body that is one major stressor away from a cascade it cannot reverse. Nobody told you that. The standard oncology appointment, 15 minutes, maybe 30, is designed to present a plan, not to surface what the plan might cost a body of 70 or 80. The question most oncologists ask is, can this patient survive the surgery? The question they do not always ask, the one that changes everything, is, will this patient be better off after the surgery than if we had never done it? Those are not the same question, and the gap between them is costing people the last good years of their lives. Here is a number that stopped researchers cold. Nearly 1 in 5 elderly patients who undergo major cancer surgery in the United States will experience what is clinically called failure to rescue, a serious postoperative complication from which the medical team is unable to recover them. 1 in 5. That data comes from the American College of Surgeons National Surgical Quality Improvement Program, the most comprehensive surgical outcomes database in the country. This is the system's own data, reporting on the system's own outcomes. There are cancer types, specific and well-documented, for which not operating is not giving up. It is not neglect. It is a legitimate, evidence-based, clinically endorsed option that produces outcomes just as good as surgery and in some patient profiles measurably better. By the end of this video, you will know which cancer types those are. You will know how to distinguish active surveillance from simply being ignored, and you will have one specific question ready, written down for your next oncology appointment. Have you or someone you love ever been told that surgery was the only path forward after a cancer diagnosis without being offered an alternative? Let's start with prostate cancer because it is where the evidence is oldest, deepest, and most conclusive. For decades, the standard response to a prostate cancer diagnosis was surgery. Remove the prostate, clean margins, done. And for high-risk aggressive prostate cancer, surgery remains an appropriate and potentially life-saving intervention. But here is what changed. In 2016, a landmark study published in the New England Journal of Medicine, the PROTECT trial, following 1,643 men with localized prostate cancer over a median of 10 years, compared 3 approaches: surgery, radiation, and active surveillance. Active surveillance meant no immediate treatment, regular PSA testing, periodic biopsies, watching carefully, intervening only if the cancer showed signs of progression. The result stopped the oncology world cold. Prostate cancer-specific mortality at 10 years was 1% across all 3 groups. Surgery did not save more lives than watching. Radiation did not save more lives than watching. For low-risk, localized prostate cancer, active surveillance produced the same survival outcome as immediate intervention. Write this down. For low-risk, localized prostate cancer, the 10-year cancer-specific mortality rate under active surveillance is approximately 1%, identical to surgical outcomes. What surgery did produce that active surveillance did not was a significantly higher rate of urinary incontinence, sexual dysfunction, and bowel complications. The treatment caused harm the cancer, left monitored, would not have caused in the same time frame. Now apply that finding to a 75-year-old man with low-risk prostate cancer, limited cardiac reserve, and early-stage kidney disease. His oncologist walks in and presents the standard plan. Nobody in that room mentions the PROTECT trial. Nobody explains that active surveillance is a clinically validated, guideline-endorsed option. Nobody says the words equivalent survival. The guidelines your oncologist follows were written with that data, but the 15-minute appointment was not designed to surface it unprompted. Nobody told you that. In 2023, the American Thyroid Association formalized active surveillance as a standard management option for low-risk papillary thyroid cancer, tumors under 1 centimeter, confined to the thyroid, with no lymph node involvement. A study tracking these patients for up to 10 years found that fewer than 4% showed any meaningful progression. Over 96% remained stable with monitoring alone. Yet surgery remains the default response in many practices, because surgery is what the system knows how to do, because presenting watchful waiting requires a longer conversation than presenting a surgical plan. Drop a comment right now. Did you know that active surveillance was a formally endorsed option for certain types of cancer? I want to know what information you walked in with. Here is what active surveillance actually looks like in practice.
because this is where the misunderstanding runs deepest. Active surveillance is not doing nothing.
It is a structured clinical protocol with defined monitoring intervals, specific imaging schedules, and predetermined criteria that trigger intervention if the cancer changes behavior. For prostate cancer, that typically means PSA testing every 3 to 6 months, a repeat biopsy at 1 year, and then periodic biopsies based on findings. If PSA velocity accelerates beyond a defined threshold, or if a biopsy shows the cancer has upgraded in grade, the protocol moves to treatment. The door to intervention does not close. For papillary thyroid microcarcinoma, surveillance means ultrasound of the neck every 6 to 12 months for the first 2 years. If the nodule grows by more than 3 millimeters in any dimension, or if lymph node involvement appears, surgery is recommended. Otherwise, monitoring continues. Active surveillance requires a patient who shows up. It requires a physician who monitors carefully. It is a partnership built on agreed thresholds and mutual accountability, not an absence of care. What has been preserved in the meantime is quality of life, continence, sexual function, thyroid function, the ability to recover from monitoring procedures which are far less physiologically demanding than a major resection. For an 80-year-old, that is not a small thing. Before I get to the third finding, the one that will change how you think about what your oncologist owes you in that appointment, I want you to understand one more cancer type where this evidence is now impossible to ignore. If your oncologist told you that monitoring carefully was clinically equivalent to operating for your specific cancer type, would you have known it was your right to choose that path? DCIS, ductal carcinoma in situ. If you are a woman over 60 who has had a mammogram in the last decade, there is a meaningful chance this term has entered your life, either directly or through someone you know. DCIS is abnormal cells confined entirely within the milk ducts of the breast. By definition, it has not invaded surrounding tissue. By definition, it has not spread. In the traditional staging framework, it is classified as stage 0, the earliest possible finding. And for decades, the standard response was immediate surgery, lumpectomy, often radiation, sometimes mastectomy, because the word cancer was in the room and the system's reflex was to remove it. Write this down. A major analysis published in JAMA Oncology examining outcomes data from over 100,000 women diagnosed with DCIS over a 20-year period found that the 20-year breast cancer-specific mortality rate was approximately 3%, regardless of whether women received surgery, radiation, or more conservative management. 3% over 20 years. In a 70-year-old woman, 20 years is a full life, and the data shows that the DCIS itself was not the primary threat to that life in the vast majority of cases. What was a threat? The surgical complications, the radiation side effects, the anxiety and physiological stress of aggressive treatment for a lesion that, in many cases, would never have progressed to invasive cancer at all. Now here is the part the standard appointment almost never addresses. Not all DCIS is the same. Pathologists grade it, low, intermediate, or high. That grade reflects how abnormal the cells look under a microscope and how quickly they are likely to grow. Low-grade DCIS cells look almost normal. They divide slowly. They grow over decades, not months. In a 75-year-old woman, a low-grade DCIS finding may represent something her immune system and surrounding tissue would have contained indefinitely had it never been found. The mammogram found something real, but real doesn't always mean immediately dangerous. and dangerous doesn't always mean the danger outweighs the risk of treating it. The distinction between grades matters enormously for the treatment decision. A woman with high-grade DCIS, cells that look markedly abnormal, with features associated with faster progression, faces a different risk profile than a woman with low-grade DCIS.
Yet in many practices, both receive the same default recommendation. This is the conversation most women never get to have. A recommendation is not a verdict. The myth this video exists to correct is deeply human. When we hear the word cancer, we activate a primal response, remove the threat, act immediately. The instinct to cut out what is trying to kill you has saved millions of lives and will save millions more. But that instinct was built for a different set of circumstances than a low-grade, slow-growing finding in a person whose body has already lived 7 or 8 decades. Here is the analogy that makes this clearest. Imagine a small crack in the foundation of a house. In a new house, you fix it immediately. You have decades of load-bearing ahead, and a small problem left unaddressed becomes a large one. In a house that has stood for 80 years, is structurally sound, and will outlast its current occupants by many years regardless, you monitor the crack. You check it every 6 months. You intervene if it widens, but you do not tear out the foundation to address a crack that has been stable for years. The risk of the repair may exceed the risk of the crack. This is not defeatism. This is engineering, and it is increasingly how the best geriatric oncologists think about cancer management in older adults. 3 cancer types, 3 bodies of evidence. For low-risk prostate cancer, active surveillance produces equivalent 10-year survival with dramatically less treatment-related harm. For low-risk papillary thyroid cancer under 1 centimeter, over 96% of patients show no meaningful progression under structured monitoring. For low-grade DCIS, 20-year breast cancer-specific mortality is approximately 3% regardless of treatment intensity. These findings are published in the New England Journal of Medicine, JAMA Oncology, and the American Thyroid Association's own clinical guidelines. This is not fringe medicine. This is mainstream evidence that has not yet fully reached the mainstream appointment. Has anyone ever sat with you, or someone you love, and walked through what watchful waiting would actually look like, step by step, as a real alternative to surgery? None of this means surgery is wrong. Let me be direct about that. For high-grade, aggressive, rapidly progressing cancers, surgery saves lives every day. For younger patients with full physiological reserves, the risk calculus is entirely different. This video is not a case against surgical oncology. What this video says is something more precise. There is a category of cancer diagnosis, specific tumor types, specific grades, specific patient profiles, where not operating is not giving up, where it is a legitimate, guideline-endorsed clinical choice, and where the failure to surface that choice is a gap the patient must learn to close themselves. Here is how you close it. 3 actions. Write them down. Action 1. Before your next oncology appointment, identify your cancer's grade and growth rate in writing. Ask your oncologist for the specific grade of your tumor from your pathology report. Low-grade, slow-growing tumors behave fundamentally differently from high-grade, aggressive ones. If your report uses terms you don't understand, well-differentiated, Gleason score, nuclear grade, ask your oncologist for a plain language explanation before any treatment discussion begins. You are entitled to understand what is in your own body before you decide what to do about it. Action 2. Ask directly, what does active surveillance look like for my specific cancer type, my grade, and my age? Not, is surveillance an option? That question is too easy to deflect with a generic answer. Ask what the protocol looks like. Ask for the monitoring schedule. Ask what the trigger criteria are for intervention. Ask how the published outcomes for surveillance compare to surgery in patients with my profile and my age. Force the conversation into specifics. A physician who has the evidence can answer those specifics. Specifics are much harder to dismiss than a general question.
Action 3. If your oncologist does not have a ready answer, or if the answer is surgery is the standard without further elaboration, ask for a referral to a geriatric oncologist. This subspecialty exists precisely to evaluate cancer treatment decisions through the lens of the older adult body. Geriatric oncologists perform a comprehensive geriatric assessment, evaluating functional status, cognitive capacity, nutritional state, medication burden, and physiological reserve before making treatment recommendations. This assessment changes the recommendation in a meaningful percentage of cases. It is not widely offered unprompted. Ask for it by name. You are not a passive recipient of medical decisions. You are an informed participant in your own health. 3 things from this video. 1. Nearly 1 in 5 elderly patients who undergo major cancer surgery experience a serious complication from which they do not recover. Make sure the surgery you accept is the right surgery for your situation, not the default for your cancer type. 2. For low-risk prostate, papillary thyroid, and low-grade DCIS, active surveillance is a formally endorsed clinical pathway, not an experiment, not resignation. 3. The question that opens the door is, what does active surveillance look like for my cancer type, my grade, and my age, and how do the published outcomes compare? Written down, asked before the appointment ends. If someone you love is facing a cancer diagnosis right now, send them this video. Not to frighten them, not to tell them to refuse treatment. Send it so they walk into that appointment with the right question already written down. That question may be the most important thing they bring into the room. Drop the word informed in the comments right now. An informed patient is not a difficult patient. An informed patient is a safer patient. In the next video in this series, we go deeper into the pre-surgical assessment most hospitals do not perform, and that could be the most important conversation you have before agreeing to any elective procedure after 70. It is called a frailty assessment. Most patients have never heard of it. Most surgeons do not order it unprompted. And the research on what it predicts and what it prevents is something every older adult needs to understand before they sign a consent form. That video is coming. Make sure you are subscribed so you do not miss it. If this channel gives you information your appointments have not, subscribe. New evidence translated into decisions you can actually make. What is one question you wish someone had told you to ask before a major medical procedure for yourself or someone you love? Everything in this video is for educational purposes only and does not constitute medical advice. Cancer treatment decisions are among the most complex and consequential decisions a person can face. Every tumor is different. Every patient is different. Every decision must be made in full partnership with a qualified oncologist who knows your complete medical history, your imaging, your pathology, and your personal goals of care. Nothing here replaces that relationship. What this video gives you is the vocabulary and the questions to make that relationship work harder for you.